Okay, good. The thing is that I think Visionix is an outstanding machine for a large number of cataract surgeons. It's very, very important now. For instance, in terms of the same competitors in this arena, cataract surgeons and equipments, we have aberrometers like OPD from Nidec, OPD scan, the iTrace from Tracy Technologies, and, well, the Visionix. So, how can this equipment help the workflow of cataract surgeons? Now it's the prime time, just a moment. Now it's just the prime time for aberrometry in cataract planning. So it's an opportunity. If you do have colleagues regarding cataract surgeons, you must present this technology to them, because if they learn how to use it, it will be an invaluable tool for cataract. Cataract is the most performed surgery in the world compared to any other surgery. So there's a place for this equipment. And not only that, it's very important. Aberrometry is very important nowadays for what we call premium IOLs, premium intraocular lenses, because it gives information about the pre-op analysis and also the post-op performance. Currently, the most important IOL in the market are the enhanced IOLs. These enhanced IOLs give, better near or intermediate vision, but at the cost of giving some aberrations to the lens, to the intraocular lens. So this better performance for intermediate and near vision is under aberrations. And Visionix is very well placed in terms of using aberrometry in order to understand if the lens is performing well or not. So, aberrometry is the name of the game nowadays. Aberrometry is in the market for about 15 years, but now because of these IOLs, it will come the golden age of aberrometry. So, cataract surgery, as I mentioned, is the most performant surgery in the world. So, there's no doubt that the equipment, Visionix VX series, or any aberrometer, has an important place in cataract surgery. Well, when we think of cataract, we think of the performance of the visual system. And when we think of the visual system, it's quite different from an optical system. An optical system would be compared to a camera, for example. It has just a system of lens and capturing the image. But our eye is connected to the visual system, which is the cortex, which is the brain processing, which is the software, I would say. So it's very important for us to understand the whole visual system in order to, whenever we assess a cataract, we plan in terms of how can we analyze the current status of the eye before the surgery, and then after the surgery in terms of the options of intraocular lens that you have. Well, actually, in terms of the cataract, we know that it's an optical system. So we have the cornea, which is a very high-powered lens as well. The cornea has about 40-something diopters. My glasses have 1 diopter. Cornea has 43 diopters. It's awesome. Positive 43 diopters. Well, the inner lens, the lens has 20-something diopters. So the whole eye has about 60 diopters. 60. It's a very powerful optical system in order to point a single focus on the retina. So the game is, we have to assess how the most external lens behaves in terms of aberrations, the coin itself. So then we have to assess the lens, the internal lens, which develops into cataract, in order to replace the cataract and give, I would say, a better vision than this patient was when he was young. So I should change this natural lens either in cataract or even in transparent lens, because sometimes one option is not to delay the surgery. You just replace the lens, the internal lens, with an intraocular lens to give, for example, multifocality, so this patient does not have to use glasses anymore, or addressing the astigmatism. So this patient depends less on his glasses. When we assess the cataract, one thing is that we have to understand that there's a difference between the optical system when you're young and then when you're older. For example, when you're young, the internal lens is quite good. It forms a very nice focus on the macula. But when you get older, this example shows a 72-year-old eye, the focus is not that good anymore. But the thing is that the cornea hasn't changed so much during all this time, but rather the internal lens has changed because of cataract, because of changes of shape, etc. So it's a bad quality internal lens. So that's why the focus is not that good anymore. You're thinking you have bad vision and you think on performing the surgery. This imperfection in the internal lens due to cataract and also the aging of the lens induces several disturbances in the vision. For example, the halos and glare that you have when you see the lights. So this is the vision that one would have in, for example, with 60 years old, a cataract. He has poor vision. He would need glasses to enhance his vision, but with not great quality. And whenever you perform a surgery, you implant, for example, a nice trifocal intraocular lens, then you regain your vision in terms of distance, near, intermediate vision, but also you have more contrast sensitivity in your image. So this is the main objective of the cataract surgery, but you see, it's quite different with the technologies we have nowadays with the current intraocular lenses. It's quite difficult for you to have the same vision you had during your younger years because the current IOLs, the current intraocular lenses, they do split light energy in order to form near and intermediate and distance vision in order to form three foci. On the other hand, when you're young, because of your internal lens changes its power, you have all the distances, but without splitting the light energy. That's why in a younger eye, you have better quality of vision. Well, the surgery itself is quite straightforward. You have to remove the cataract and then you have to replace it for an IOL. But where does the aberrometry enter into this game? Whenever you remove the internal lens, either due to cataract or either due to aging, you will be left with the cornea and a new lens, a new artificial lens. And it's very, very important that this new lens couples with the cornea. So any information regarding the cornea is vital for my analysis, for my planning. Visionix gives the full amount of information for me in terms of, for example, the cornea performance before the surgery. This is a very, very interesting example of one of my patients. After the surgery, I performed the surgery of this patient because of cataract, and I implanted a trifocal IOL. And after the surgery, he brought me this drawing. He mentioned that he saw the headlights of the cars like this, with halos and like stream. And he drew this image for me to illustrate how he saw the lights. And now I don't have to rely only on his information or on his goodwill, because he drew what he was feeling. I have now instruments. I don't have to fly blind anymore. I have, for example, the Visionix, which has a placido topographer, which has a Hartmann check barometer with high density of analyzer. So I can assess either in pre-op or post-op the eye health. It gives me the IOP. It helps me to assess his eye fundus with a retinography. It helps me to assess the cornea and surface. What do I mean by surface? Because it allows me to assess the tear film as well. So, placido topography, corneal aberrometry, and tear film analysis. Tear film is very important. We don't presume it is that important. But if you compare with your eyeglasses and you have dirty in your eyeglasses, you will feel that your vision has gone worse. But it's all because of this surface of your eyeglass that is not okay anymore. So it's about the same in tear film. You have to have a pristine tear film in order to have a good vision. And Visionix also gives me pupillometry, because pupil is also important in terms of light entering your eye and giving more quality of vision or not. Total aberrometry, internal aberrometry, metrics for quality of vision, for example, PSF and MTF. PSF being point spread function. What's point spread function? Which seems like complex, but it is not. It is how we see a point. Is it a point, just a point, or it's a blur? For example, this patient, he saw a car light, which should be a point of light, but you saw that he drew like halos and streaks. So PSF gives me this idea if he sees a point, just like a point or not. MTF is another concept that could be complex, but it is not. Complex is modular transfer functions. Visionix gives me that. What is modular transfer function? It's the relation that how much the optical system eats the quality of the image. For example, if I have an object here and I have a lens here, the image that will be formed will not use 100% of the image, because sometimes something will be lost in the lens. So if 100% of information of this object comes to the lens, there is no way that 100% of this information will come to form the image. something will be eaten by the lens. So this relationship, this number, the MTF, translates me how good or how bad a lens is. Every lens has a number of quality. So, for example, some intraocular lenses give me a better or worse MTF. So, maybe one patient with one lens, one intraocular lens, and the other with another intraocular lens, they can have different quality of vision because both of these lenses, they perform differently. They let more energy pass or not. So it's an important number, important information for me to understand the result I can give to the patient. Angle kappa, angle alpha. Currently, we use a lot of trifocal IOLs, for example, which they do have rings, and these rings have to remain in the center of the visual system, the visual axis. Sometimes, more often than not, some intraocular lenses, multifocal intraocular lenses that we implant, they do fall slightly off my visual axis. So the information that angle kappa or angle alpha gives me is how this center of the eye and the center of the vision is off or not. If a patient preoperatively has a high kappa angle, I know that maybe it's not suitable for diffractive IOL because the center of this IOL may fall outside the visual axis. Then, very importantly, toric planar and toric check. For patients with astigmatism, I can implant a toric IOL, and then I can not only plan with the equipment, but also I can check it afterwards. I can check with retro illumination as well to see if the lens is well implanted in the right axis. So the Visionix has a very nice aberrometry system. We do have different concepts for aberrometry, like ray tracing, like rotating ischemoscopy. The ray tracing is, for example, in the eye trace equipment. The rotating ischemoscopy is on the OPD from NIDEC, and the Hartmann check sensor is in the Visionix, in which we have a system of multiple lenslets that read the incoming rays that were emitted by the equipment, and then it reads the profile of these incoming rays to draw a map of aberrations. And this is the basic map. Visionix has several maps in order for you to assess the eye, but this is the main one. We can have, for example, it's very, very interesting because in just one screen, we can have it all. Pupillary distance, in this case, 65.5 millimeter. The refraction, you use your glasses, but it's interesting because Visionix gives me refraction depending on your pupil size. Sometimes it's very common for myopes to have worse vision at dusk. So why is that? Because you can have a refraction, in this case it's not, but you can have refraction that is different in mesopic and scotopic situations. In this case, the measurements were in 2.9, 3.0 millimeter of pupil, and then in 3.5 millimeters. So one refractometer, regular one, does not provide me this information. And also, with some patients, they can complain of their vision during different settings. When I'm walking in the street and then I got in the tunnel, my vision is different. So this superior part of the screen can give me a hint of what's happening, and then I explain to the patient what's going on. The topography, as you click one of these maps, it's enlarged, but it's a very nice possible topographer. It also gives me the simulated keratometry with the average as well. It also has a shine through camera. It's not compared to the Pentacanal Galilei, but it's shine through camera gives me the information of the anterior chamber. You can click on the image and it gets enlarged, but also you can have the pachymetry of the cornea as well. You have the tonometry. It's amazing because the equipment is like a robot. It moves and changes to the applanation, the puff tonometry, and gives me not only the tonometry, but it measures the cornea. It can gives me the corrected intraocular pressure compared to the cornea. It's important to correct the intraocular pressure, especially on those patients who had undergone refractive surgery and that they have thinner corneas, and you have to correct the reading. So this is a basic overview of the system. So again, you have the refraction, you have the topography and keratometry, you have the shine field image with the pachymetry, tonometry, and as I mentioned, you can enlarge the information of the topography. And again, I have to stress out that it's very important. Although the Visionix VX 120, 130, and VX 650, they do have a barometer, which is very, very nice, but they do have a very, very well-constructed, well-built Placido topography. Placido topography is a deal breaker in terms of analyzing pre-op of cataract. For example, in this case, you can see the aspect of the cornea in terms of its morphology, but as well the numbers. You can have in the right eye, you have a cornea with very high numbers of keratometry, a very high astigmatism up to 9.25 of astigmatism. In the other eye, although it has some quite, I would say, nice numbers in terms of keratometry, you have low astigmatism in terms of the cylinder, but the map is not that good. You see that it's quite irregular. It also gives me in red some remarks for me to pay attention, especially when I'm planning a surgery. So my eye gets attracted by these red alarms, and it gives me automatically alerting me that this eye has, I would say, very high aberrations. So it's not a good case for premium IOLs. It gives me an overall glance on the patient's cataracts. I can just click in this screen and enlarge to show the patient his cataract. Maybe sometimes it's not that tangible for him to understand his cataract. So this retro illumination image shows the cataract, his cataract very well, and I can show off to the patient, and I can also grade the cataract based on these standards. It's interesting because I can also, for example, this is a retro illumination documentation of diffracted multifocal IOL. So we can see the rings here, and we can see from the shine through map how it is placed. We can see, for example, let me go back. If the patient has some problems in his posterior capsule as well, because of the retro illumination. And then what is so interesting and so unique in this equipment, other equipments, they don't give this important information. For example, eye trace or OPD scan. The kappa angle, in degrees, eye trace in OPD scan, they do give correlated information regarding kappa angle, but in micron. But actually, the real good information would be in degree. So Visionix is the only one here in yellow, the information of the kappa angle in degrees. So it's very important information for the surgeon who is planning to implant multifocal IOL, and then he can consider if the kappa angle of this patient is high or not. Amazingly, it's equipment that can assess the tear film as well, as I mentioned. So it's important for our catheter patients to have the most pristine vision because of these lenses. So the Visionix also gives the VX 130 gives the map of the tear film. For example, in this patient, you can clearly see that some part of this cornea is suffering because there is some fluorescence being marked in his cornea. And we can also see in the breakup image that his tear film is not that good. So sometimes you have to plan before the surgery to treat his tear film in order to have a successful performance after the surgery. These are my cases. So these patients I treated before the surgery, and before he enters my office, I knew his problem because I received the reports before he enters my office. So I have the whole information. I'm just confirming in the Swift lab. I can show off before and after treatment, and this is a great difference in the performance if I plan to make a surgery in this patient. One very nice thing in the VX is the aberrometry. This is the internal aberrometer, as I mentioned. Nowadays, we are in the golden age of aberrometry and catheter. These are aberrometries performed in post of my patients. I implanted these modern enhanced intraocular lenses, in this case, the Reiner EMV, and the Reiner EMV gives a nice vision to distance and a very good vision to intermediate. But how does it do that? It does by giving me distant vision in the center, which is in blue, and in orange and red, it's the near vision. It's peripupillary. So it's about the same in both eyes. And if you ask the patient, can you see to the distance vision? And he says, yes, I can, doctor. And you wonder, how can he see? And you can have a glimpse just by looking at his map. So the Visionix gives me this 3D perspective of the aberrometry. And I know that this IOL is performing well. But what is this importance? Because if the patient is satisfied, maybe I wouldn't need this image. But if you have the same patient and he could complain that the results is not that good, you could rely on the aberrometry in order to understand, well, does he have the distance and the intermediate vision in his eye or not? A barometer can answer that. So again, you can see the barometry in 3D in both cases. Again, a EMV radar intraocular lens, and in which it provides a distance vision in the center and an intermediate vision in the periphery. It's very clear. No other equipment gives me this kind of information. On the other hand, I can know how the patient is seeing. It simulates the vision of the patient as it collects the whole barometry, the pupil information, his cornea information. It takes all this information, all the data, and it makes a convolution. It makes like an analogy to his vision. So I can have his vision correlated to the letters, but also to the PSF. Look at this. His PSF. It simulates how he sees a point of light. It's not a point of light. It's spreading. So before he tells me, I can understand him, or I can trust him more, or not. I can assess his vision with the Visionix. Again, now I can see that this patient specifically, before he tells me he has a better vision, he sees very well. The point spread function is quite good. It's quite good. It's different from the previous patient. So I know that the quality of the vision of this patient is very good, and I can tell him before he points me out. And then there's this screen, which seems to be complex, but I can guarantee it's not that complex. For example, this means that I can understand the quality of the vision of the patient with this simple graph. And how do I interpret this graph? Well, there's the curve. The green curve would be the optimal non-human optic system. There's no human with this green system. Our system is not that perfect. We lose something of the information of the image in our ocular system. So, without correction in blue, without glasses, I lose much of the quality of the vision in both eyes. We can see this curved blue line, which translates me that it has low quality of vision. And I tell him, well, I'm going to give you a new pair of glasses, and the system, the Visionix, takes the information of the prescription you're about to give him and inputs in the current status of his eyes, and then it corrects his MTF information. So it's this yellow line, and it shows me that his quality of vision will improve in this yellow line after he uses his eyeglasses, his new eyeglasses. It's about the same in cataract surgery, in which we can assess if there will be an improvement in his vision after the cataract surgery. So it's a very elegant, very important information that seems like complex and very scientific, but it's very useful for a patient in the office. Well, I can tell you that this yellow line, which seems a little bit depressed, but it's quite the normal young quality of vision in humans. No one has, as I mentioned, this 100% of personal performance. There's a slight curve. As much as this curve is depressed, the quality of vision is worse. So Visionix is like having a very complex airplane, but now you don't fly in the blind. You have the full information in order to have the safest analysis, pre operatively and also assessing the performance after the surgery. So I used to use the Visionix to inform the patient. As you saw, it gives me a projection of how he sees a point, or how he sees the letters. I can show him, and I do show him. And patient gets impressed because he says, wow, that's the way I see the things. I use so many other informations regarding the pre-op planning and also for the post-op analysis, even in cases that were not that successful. For example, in this case, I have this map is very important. It's the reflection of the placido rings on the cornea. So by looking at this, I see that it has this patient has a very, very irregular cornea. If I implant a trifocal lens in this patient, it will be a mess because this cornea doesn't couple and doesn't talk very well with the trifocal IOL. So it's an information that I have before the patient gets into my room. So important. He gets amazed because sometimes the patient enters my room and he says, oh, I want to use a trifocal IOL like a friend of mine, and I tell him, you cannot. How do you know that? Before I examine the patient, because this exam was performed before he enters the room. So again, I know I can tell him, oh, your surgery that you made a couple years ago or many years ago is now interfering with our planning. How do you know, doctor? Oh, I can see the scars or the cuts on the cornea that you have in both eyes. How did you see that? I have in my computer now. I know how bad you see. How do you know how I see, doctor? You didn't put me on the examining chair. I know how you see the letters. I know how you see the lights. Can I show you? And he points me. That's the way I see. Nobody knew. Nobody understood me. My complaints. Well, the machine does, and I do. So this is the kind of patient that in the beginning, when we didn't have this kind of tools, we didn't understand him. What is he drawing? What is this starburst when he sees? And you know, this patient is helping me. He's trying to help me. But now I can have, for example, the same information. This is a machine information. And this is the patient information. It's about the same. Just by assessing his eye with the computer can draw me the same as he tried to convey to me. It's impressive. It's impressive. Okay, I think it's actually it's a brief talk about the Visionix because I'm so excited to use aberrometry and all the tools that the Visionix provides to my patients before the surgery, as I showed. It's amazing to see the faces of the patients, and they never had this experience before. Whenever I show them the screens and displays of the Visionix and explain what they feel, they get amazed. They really do. And it's very important for them to understand what they have, for me to have the cooperation for the cataract planning. On the other hand, as I showed, it's an invaluable tool for the performance after the surgery. Sometimes you have poor results and you keep on guessing what happened. I have so many colleagues that felt trapped in some questions regarding, oh, I have implanted these IOLs and they're not successful. I don't know what I'm doing wrong. Well, that's why I say that This is the golden age of aberrometry. So I think Visionix is very well placed in this area. I really want to help doctors. I have a very great work in Latin America regarding teaching, and I love to help doctors and also distributors to bring this technology to the patients. I will make sure that I give Visionix some papers and some studies in order for you to have more information on how to use these resources to the doctors. And if you have any doctors in your area that want to know more about the Visionix and cataract workflow, please feel free to connect me to them. I will be more than glad to help. Thank you so much.